So last talk on the hip. So hip arthroscopy has become a big part of orthopedics in the last decade and a half. It is still something that is new to many people, particularly the pathology related to that. So mostly we're talking about femoral acetabular impingement. Everybody talks about labrum tears. The labrum tear is usually the least important part of all of them, even though that's what people tend to focus on, because it's easy to see on an MRI. So usually that is caused by malalignment, just like all the other things we just got done talking about. A similar issue is malalignment then causes other secondary concerns. So we're going to skip past just about most of this. So keep in mind, groin pain is the key here. So it should be deep in the groin. It should not be lateral. It should not be buttock pain. Those things we can rarely help with this. There are exceptions to that, but groin pain is the key here. So osteoarthritis, we cannot help in most cases with hip arthroscopy. So if they're bone-on-bone osteoarthritis, they're not going to do well with the hip arthroscopy. They should have something else if they're impaired function. So we're just going to briefly go through pincer lesion. So here's a little illustration. So this is a pincer lesion here. So this is the way that it does damage to the labrum and articular cartilage. So that is a pincer lesion right there. Okay, so how about cam lesion? Help if I went the right way on the slide, right? So here's a cam lesion named after the device on a camshaft. So cam lesion exists typically on the femoral neck. Here you can see the cam lesion itself right there. So that prominence, when the hip is driven into a forward flex position, will then damage the articular cartilage and the labrum. So the labrum and articular cartilage damage tend to be, particularly the labrum, more than end result of femoral acetabular impingement. It's not the first component. Usually pain and other issues are going to be the first components to that. So here's the concept. So again, typically it's going to be deep within the groin. Our physical exam rely on flexion, adduction, internal fixation, flexion, adduction, internal rotation. Injections are very helpful. Any questions so far? All right, so here is a torn labrum. See probe right here. This is the femoral head right there. It's acetabulum. And so our goal, so if you're seeing patients that are continually having labral debridements, so we know the outcomes are tremendously better if we can repair the labrum, preserve the labrum. So our goal when doing hip arthroscopy is to try to do everything possible to help preserve that joint and maximize long-term function. So that involves, in most cases, a labrum repair and even consideration for a labrum reconstruction if we have the right patient and indications. Otherwise, we probably have maybe 2 to 4 patients per year where we're unable to repair the labrum, so it's very rare. In most cases, we're able to repair it. We try to do everything possible, just push the envelope of repair, just like with the meniscus, for almost the same reason. So here's a case, patient, typical cam lesion. They have actually mixed type FAI, so cam lesion and a labrum tear. So they have over coverage right here. They have also a moderate cam lesion. Again, and you can see fairly substantial prominence right there. So here he is on axial MR imaging. So that's what we're going to address in this time of surgery. So here's the central compartment, labrum tear, femoral head right here, acetabulum here. And again, labrum here. This is the acetabulum right here. So this bone we trim back with the burr right here. So we trim that back. About 3 to 4 millimeters in this case, repair that labrum back to the acetabulum. And here is an anchor, passing sutures, tying sutures. Here's an intraoperative x-ray that we also utilize to make sure that we like where things are located and look at the big picture. And then we need to address the other bony component so that we resect that also. So this is now anterior and somewhat lateral in the femoral neck. Here is the bony resection. There is post-op, intra-op, I should say, after bony resection. So then we take that person with the scope in the hip and the x-ray, and we literally drive their hip up into this position and make sure that we do not see direct bone-to-bone contact. And that's our litmus test for have we adequately debrided and resected the cam lesion and or the pincer lesion. We also try to treat more of these on the femoral side because it's safer. There's lower complication rates with that. So unless there's severe pincer impingement, most time we'll treat it on the femoral side. So here's another labrum tear here, tear here. So, and then resection here. And this is a pincer resection in addition to cam resection. Preparing labrum. See if our video will play. Maybe.
I don't think that's the video one. I think it's a few slides down.
All right. So another case. So this is the labrum here, femoral head, and the acetabulum.
Dr. Juelson?
Yeah.
Are those always injury related, or can there be other causes?
So it's usually a mix of things. So almost all of these things, not 100%, but most are caused by the bowel alignment, the femoroacetabular impingement. So that then, with some active individual driving that hip hard and in a flexed position, it causes these other symptoms. So that's why we have to be very cautious about focusing on the labrum. That's what people like to talk about. But again, that is an end result. If we fix the labrum, leave the other things, the labrum will be torn again in 6 to 9 months. So that's why we got to treat the whole picture. There you go. So here is labrum right here. This is a wave sign. This is somebody with cam impingement. You can see as the probe moved, this is labrum, and the probe is moving over the articular cartilage. So see how the articular cartilage is moving under the probe. So that is occurring because that area has continually been impacted by the femoral neck or the cam lesion. So you can imagine this is a young patient, so you can imagine this continues to occur. This is how people get early osteoarthritis in their hip, is one of the main causes. And that is, at this point, well documented, well established in literature. So take-home points, education. So this is something that we're still trying to educate people about. Some people will see it across the room, but it's one of those things that we all need to learn more about and try to make sure these patients are getting to the right place. Probably 1 out of 5 of these patients that we see, they've been told they're crazy for a couple of years, and then usually they're not. Usually it's a fairly straightforward explanation. So keep that in the back of your minds.